Three patterns of acute renal failure were described following open heart surgery nearly 25 years ago and in principle still hold true today. In the first termed abbreviated RFA, a transient intraoperative insult occurs that causes renal failure, renal ischemia. The serum creatinine peaks on the fourth postoperative day and then returns to normal. In the second pattern, termed overt acute renal failure, the acute insult is followed by a more prolonged period of cardiac dysfunction. The creatinine usually rises to a higher level and gradually returns towards baseline over the course of 1 to 2 weeks once hemodynamics improves. The third pattern, protracted RFA, is characterized by an initial insult followed by a period of cardiac dysfunction that resolves. Just as the creatinine begins to fall, another insult occurs, often from sepsis or a period of hypoperfusion, hypotension that triggers a progressive, often irreversible rise in creatinine. Now we are going to look at this figure 12.5. Pattern R, surgery, and after the serum creatinine is going to be normal. So pattern B, surgery, impaired cardiac function, then improved cardiac function. And pattern C, surgery, poor cardiac function, then the septic shock and another causes may add to this scenario, and acute protracted acute renal failure, the reduction in creatinine clearance may be occur. Assessment. Assess cardiac hemodynamics, filling pressures, cardiac output. If the patient is no longer being intensively monitored, insertion of a follow catheter is helpful in assessing urine output. Evidence of jugular venous distension or orthostatic vital signs raise the specter of tamponade. An echocardiogram may be considered to assess ventricular function and the presence of a significant hemopericardium. Identify any drugs being prescribed with potential adverse effects on renal function. Obtain a serum, blood, urine, nitrogen, creatinine electrolytes, and osmolality. An elevation in creatinine with minimal or parallel rise in blood, urine, nitrogen is frequently noted with acute kidney injury. In contrast, a disproportionate rise in blood, urine, nitrogen with little rise in creatinine may reflect the prerenal process or increased protein intake, total parenteral nutrition, gastrointestinal bleeding, hypercatabolism, or steroid administration, which increase urea production. Examine the urinary sediment. Tubular epithelial or granular casts are indicative of tubular injury, whereas hyaline casts are seen in low perfusion states. The sediment is important to examine because tests of tubular function, such as the urine, sodium, and osmolality, may be inaccurate with use of diuretics. Measure the urine sodium and creatinine concentration and the urine osmolality. This test can differentiate prerenal from renal causes, but their interpretation will be influenced by the use of diuretics. Urine sodium below 20 milliequivalent and urine osmolality more than 500 milliosmolar kilogram are strongly suggestive of prerenal disease. However, in oliguric patients, in the urine sodium will rise as the urine volume falls, leading to a higher urine sodium even in prerenal states. In this situation, calculation of the fraction exertion of sodium is helpful, where U and P refer to the urinary and plasma concentrations respectively of sodium and creatinine. In the oliguric patient, an fractional excretion of sodium below 1% reflects retained tubular function with absorption of sodium and water. Consistent with the prerenal problem, expect in cases of contrast, nephrotoxicity, and hepatorenal syndrome. In contrast, an fractional excretion of sodium more than 2% is usually caused by acute kidney injury. However, this may also be noted when a prerenal process is superimposed on chronic kidney disease. When the kidneys at baseline cannot conserve water and sodium appropriately, a rise in fractional excretion of sodium may be noted during recovery of renal function due to sodium mobilization. Monitor other electrolytes, blood glucose, and acid-base balance frequently. Obtain a renal ultrasound to assess kidney size and rule out obstruction. A renal scan may be performed if a renal embolus is suspected. Now we are going to see the table 12.5, evolution of the etiology of oliguria. Blood urine nitrogen and creatinine 20.1, this is prerenal. 10.1, this is renal. Urine and plasma creatinine more than 40, this is prerenal. Below 20, this is renal. Urine osmolality more than 500, this is prerenal. Below 400, this is renal. Urine plasma osmolality more than 1.3, this is prerenal. Below 1.1, this is renal. Urine specific gravity more than 1.016, this is prerenal. Below 1.010, renal. Urine sodium below 20, this is prerenal. More than 40, this is renal. Urinary sediment, hyaline cast, this is hyaline cast, this is prerenal. Tubular epithelial cells, granular cast, this is renal. Now we are going to management of oliguria and acute kidney injury. Early aggressive intervention in patient with oliguria and early evidence of acute kidney injury may prevent progressive tubular injury and worsening of renal function. However, once acute kidney injury is established, very little can be done to promote recovery of renal function. However, once acute kidney injury is established, very little can be done to promote recovery of renal function except to prevent additional insults. There is little evidence that strategies that increase renal blood flow or increase urine flow to reduce tubular obstruction have any impact on enhancing tubular epithelial cell proliferation and recovery of function. Generally, attention should be directed towards maintaining urine output to reduce tissue edema and treating electrolyte or metabolic problems as they rise. Ensure that the follow catheter is in the bladder and is patent. This may rule out an obstructive uropathy. Irrigate with saline if necessary or consider changing the catheter empirically. If the Foley catheter has been removed, a bladder scan may indicate whether oliguria is renal or spurious. A significant post-void residual may provide evidence of a post-obstructive uropathy as the cause of an elevated creatinine. Either way, replacement of the catheter may be helpful in further assessing the urine output. Discontinue all potential nephrotoxic drugs and avoid any diagnostic studies requiring IV contrast. Optimize hemodynamics. Also, augmenting a good cardiac output may not be able to expedite recovery of renal function. It is clear that any additional insult that causes hypotension or hypoperfusion may contribute to a state of protracted acute renal failure. These insults include hypokalemia, low cardiac output states, arrhythmias, antihypertensive medications, or sepsis. Thus, there is little downside to optimizing hemodynamics to increase urine output, even if the rate of renal recovery is not hastened.